So it's 6 p.m. and I'm going to start. Good evening to all those who are tuned in to our interesting talk through the NHI Alumni Association. And we try to bring you interesting lectures almost every month. And today is no exception. And our
Itzar, you can't hear you.
Did you lose? Oh, Itzar, turn you're muted. You flipped to mute. Okay, go ahead.
Can you hear me now?
Yes.
Yeah, now that you're unmuted.
Okay. Anyway, the speaker today is no other than Dr. Norman Lepor, whom you met before. Norman is a alumnus of Cedars-Sinai Medical Center. He has been for many years interventional cardiologist. He's still interventional cardiologist, but his major interest is in prevention and treatment of heart disease through medications. And he's really in almost every field of cardiology. And he's a very good and interesting speaker. So today there's going to be a follow-up on his previous talk about obesity. It's a situation that is not only not aesthetic, but can be very dangerous and must be treated. And today we have new ways to treat obesity. So we are looking forward to hear from Dr. Lepor. After his talk, you'll be able to ask questions, and I'm sure he'll be happy to answer. So Norm.
Thanks, Itzar. It's my pleasure and honor to be selected to present. We're going to talk about obesity, a big problem, new understanding, and treatment. I'm going to go pretty quick, a lot to cover. There'll be pearls for those of you who are more lay people, and certainly there will be a fair amount of biology that will be perhaps more interesting to those who are active in treating obesity. So thank you very much for the introduction. Let's see. So let's define the problem. This is the definitions of obesity. Basically, you're considered obese with a BMI, body mass index of 30 or higher, the different classifications within that. And severe obesity is defined as a BMI of 40 or greater. And we'll talk about how that's actually defined. There are a lot of controversy about using a BMI because it doesn't really distinguish people who may have high weights but are more muscular. So it doesn't really necessarily do a great, it's not very effective in terms of defining true adiposity. We have the waist circumference, which some people prefer. That's defined in the European type people to be in women 35 or more, in men 30 or more, and probably the best assessment is the waist to height ratio. This probably gives a better definition of adiposity, more consistently related to visceral adiposity. And what we can see here is a relationship between these three measures and all-cause mortality. What's interesting is that BMI has this V-shaped curve where actually you see increases in mortality as you go from a BMI of about 25 to 15. Whereas the waist height ratio that we talked about, that actually has a pretty linear relationship. So it's more consistent in terms of showing a relationship between increases of waist to height ratio and increases in mortality. So this is a pretty sad state of affairs. This is looking at overweight and obesity. Overweight we would consider BMI of 25 or higher. And on the upper left, we're looking at older adolescents, aged 15 to 24. And you can see that the prevalence, most of these states are in the light blue. You're talking about a prevalence of 45 to 50%. So here come the reinforcements in our battle of the bulge, these young people who are destined, many of whom, to become obese. It seems to be among the younger people. You can see more red on the right, which are older adolescent females. In part C, down lower, you can see there are parts of the country where the prevalence of overweight and obesity are up to 80%. This is really in the central part of the country, in what we call the Bible Belt. And when I go around the country and talk about this, I tell them the reason they call it the Bible Belt is that they're so obese and have so many comorbidities, they actually have to pray for long life. And you can see it certainly is a bigger problem among adult males versus adult females, but certainly females are not immune from being obese. This is very sobering. This is actually looking at adult obesity rates in 2024. You can see that there are a large number of red states. In this particular situation, red is different than in the political domain. So we can see a large number of states, particularly in the South and Midwest, where obesity rates are in excess of 35%. California actually has a lower obesity rate than most states in the country. Obesity still is a problem with rates between 25 and 30%. So this is obesity, not just obesity and overweight. So we know that there are a variety of causes of obesity. There are genetic predispositions. We've studied actually genetics, Mendelian genetics, which shows there are different genes that actually predispose to obesity. There's neurologic and psychological factors that can be associated with obesity and the drive to eat. Nutrient and hormone imbalances play an important role. We'll talk about those in detail. The environment, food availability. Is food something that is given as a reward to children, and therefore it takes on that same role as we get into adulthood? And of course, medical conditions and medications that we see this in are particularly the antidepressants and beta blockers. And then you can see on the other side, on the downward part of the slide, this is the resulting comorbidities, an increase in type 2 diabetes and insulin resistance, the development of hypertension, the inflammatory state, which we know is associated with obesity. Check HSCRPs in your obese patients versus your non-obese patients, and you'll be surprised to see probably 30 to 40% of these patients have elevated CRP levels. Dyslipidemia, particularly the mixed dyslipidemia with elevated triglycerides, low HDL, and sleep apnea is an important comorbidity associated with the obese condition. One of the issues is we've become a much more sedentary society. This is looking at data from 1960 to 2010, and what you can see is over time, the mean occupation-related METs it has really gone down significantly. This is how much, what your caloric expenditure is on the job. And if you look at occupation-related daily energy, you can see how basically energy expenditure has basically come down by a third. We spend too much time looking at computers, too much time sedentary in our work, and therefore this leads to a gap, a bigger gap between energy being consumed and energy being expended. These are the comorbidities associated with obesity, many of which we don't really appreciate. Certainly, there are mental conditions, attention deficit disorder, depression. We'll talk a lot about cardiovascular, which is why I'm very involved in this field, atherosclerotic coronary vascular disease, hypertension, atrial fibrillation, and particularly heart failure, coagulation, thrombosis. We see an increased incidence of deep venous thrombosis, skin ailments, in particular psoriasis, musculoskeletal issues. All of our obese patients, because of all the pressure, bad ankles, bad knees, bad hips, bad spine, malignancies, certainly not appreciated, but malignancies such as colon, breast, pancreas, there's an increased incidence in the and prevalence in the obese population. A lot more type 2 diabetes, fatty liver disease, which is the old name, dyslipidemia, gallstones, gout, reproductive issues, particularly polycystic ovarian syndrome, and pulmonary abnormalities, particularly sleep apnea. So what we see is the impact of obesity on cardiovascular disease. We see increase in valvular heart disease, particularly aortic stenosis. There's an increased incidence of, as we talked about, pulmonary embolism, deep vein thrombosis, greater incidence of atherosclerotic coronary vascular disease, heart failure, both preserved ejection fraction and reduced ejection fraction, a lot more atrial fibrillation, and not as well appreciated the increased incidence of sudden death. These are, let me just go back one slide. What we can see now is this is the results of treatment in terms of utilizing these nutritional injectable medications, such as the GLP-RAs. What we see with decreased weight, decreased CVD risk factors, decreased major adverse cardiovascular events, decrease in heart failure hospitalizations. So we really see a rather nice decreased fatty liver disease, metabolic dysfunction associated steatotic liver disease, the new name, and even a reduced progression of chronic kidney disease. This is what we're talking about with these nutrient-stimulated hormones, such as the GLP RAs that we'll be talking about in just a bit. Now, this is the extent of weight loss and impact of the weight loss on cardiovascular and lifestyle. So when you're getting 5% weight loss, which is what you can get with dieting and some of the older weight loss medicines, you do see some improvements in triglycerides, blood pressure, fasting glucose, and reduced risk of developing type 2 diabetes. So 5% weight loss is not something that's particularly difficult to get with lifestyle modifications if your patients are determined. Now we're talking about pharmacotherapy. When you start getting weight loss of 10 to 15%, which we are able to get with the GLP-RAs, we're seeing improvements in metabolic dysfunction associated steatotic liver disease, otherwise previously known as fatty liver disease, improvements in diabetes and A1C, improvements in osteoarthritis, and a reduced cardiovascular risk. Now, when we get down to about 20%, now we're getting closer to bariatric surgery. We're seeing now more significant reduction in cardiovascular mortality and heart failure events. And we'll talk a bit about bariatric surgery. We don't want to forget about that. There you're able to achieve weight reductions of 25% or more. And there we're actually seeing significant reduction in terms of the risk of mortality. So this looks at what you can expect in terms of your different goals for therapy in terms of being able to achieve incremental benefits in terms of diabetes, hypertension, heart failure, cardiovascular mortality, and overall mortality. So really it takes a comprehensive care for the patients with obesity. This is a statement from the Obesity Medicine Association, their position statement. Comprehensive care for the patients with obesity, healthful nutrition. I'm asked a lot about access to a nutritionist, physical activity. Almost more important is isometric exercise in addition to aerobic exercise, behavior modification, trying to make it so food is less of a reward, and of course, medical management. And now we have very effective injectable drugs that really help us achieve the desired weight loss. But who's to blame? The blame is the adipocyte, otherwise known as the fat cells. So we're going to blame everything, almost everything here on that poor, sad, angry adipocyte. So first of all, let's dispel the myth of the metabolically healthy obese patient. What we find is compared to a normal healthy weight individual, and you compare that to a obese patient who does not have any metabolic dysfunction, so their lipids are okay, their blood pressure is okay, they don't have sleep apnea, fatty liver, there's still about a 26 to 28% increased incidence of coronary heart disease. So, and certainly if you have the obese patient who has comorbidities, then you're talking about really a doubling of risk of cardiovascular disease. So I want to emphasize the results highlight the importance of both obesity and metabolic health in coronary heart disease prevention, and do not support the concept of a metabolically healthy obese patient. So let's get back to the adipocyte, really the conversion of the healthy to a dysfunctional adipocyte. When I was in medical school at the Johns Hopkins University, we really didn't talk about the adipocyte much. It was felt to be this really, basically inert cell that wasn't particularly involved in health conditions. Well, now we know a lot more. So here we're talking about the healthy adipocyte. That's the adipocyte that does not have, has a lower content of fat. It's a smaller adipocyte. It's actually anti-inflammatory. It actually has protective effects. So the healthy adipocyte actually gives out compounds called adipokines that have anti-inflammatory actions such as adenopectin, and actually lead to lower levels of another important adipokine such as chemerin, which is involved in inflammation and insulin resistance. So actually the healthy adipocyte actually reduces inflammation, and as long as it's happy and not overfilled with fat, it does good things. Well, then you have the dysfunctional adipocyte. Under conditions of high energy intake, these adipocytes have increased volumes, increased concentrations of fat, of fatty acids, etc. So now you have the unhappy dysfunctional adipocyte. Now it's putting out adipokines that are pro-inflammatory, like tumor necrosis factor, like monocyte chemoattractant factor, and reduces the output of adenomectin, which actually has anti-inflammatory effects. So you get immune cell infiltration, increases in inflammatory cytokines. These are the inflammatory proteins put out by these immune cells. You get negative insulin signaling, leading to insulin resistance. And you can see that obesity, high-fat diet, leading to increases saturated free fatty acids. Hypoxia leads to cellular senescence, which is cell death. So you're creating this inflammatory milieu. And one of the effects of this inflammatory milieu is insulin resistance, which is basically a very important component of the diabetic condition. And we can see as that fat cell, in this case, the white adipocyte, which is really the pro-inflammatory adipocyte, as you increase the fat storage within that cell, within that adipocyte, you see increases in terms of inflammation. So the fat unhappy cell is pro-inflammatory and expresses a whole variety of chemicals that perpetuate and perhaps even accentuate the obese state. So here we talk about the white adipose tissue. The white adipose tissue is really that that adipose tissue that is more pro-inflammatory. We talked about the association of obesity, adiposity with cancer. That's probably based on the inflammatory modulation and the development of angiogenic factors. What we can see is compared to the white adipocyte, you have the ability, perhaps under certain conditions of diet, the use of TZDs, physical exercise, to convert the white adipose tissue to this brown adipose tissue. You can see there's a lot less yellow or a lot less fat. You see a lot more mitochondria, which are those energy warehouses. And so the brown adipose tissues, it plays a bigger role in terms of anti-tumor effect, is very much involved with keeping us warm. We call thermoregulation, or our basal metabolic rate. So you can actually make conversions between this white adipose tissue, which is bad, and the healthier brown adipose tissue. So it really matters where the where the adipose tissue, where the adiposity accumulates. We know in the subcutaneous adipose tissue, which we see more in females, there's less of it with age, which is why there are many of us who seek out plastic surgery. We're losing that subcutaneous fat, which keeps us wrinkle-free. And one of the important things about it, it's actually neutral in terms of association with cardiovascular risk. So it's good that we have this subcutaneous adipose tissue. And what we try to do is have situations where we're trying to reduce weight, where we don't lose as much of that subcutaneous tissue. Then what we have, what we call perivascular fat, or similar to visceral fat. This is the fat around the arteries, around the heart. This is the fat that's around organs. I don't know how many of you have been involved in surgery, but there's nothing grosser than holding on to a heart of somebody who's obese, basically tremendous amounts of fat. And this fat accumulation is associated with an inflammatory state. It's associated with insulin resistance and has a strong association with cardiovascular risk. So subcutaneous adipose tissue, great for keeping off the wrinkles, neutral in terms of cardiovascular risk. And it's the visceral fat, which is, and the other depots of fat around arteries, around the heart, that actually have a strong association with cardiovascular risk. So why is obesity a chronic disease? Blame the adipocyte. Appetite regulation. The control of appetite is complex. It involves the integration of the central neurocircuits, including the hypothalamus, what we call homeostatic control. This is when your energy balance is negative and the body's making you feel hungry because of that. The mesolimbic system is the hedonic control. So the hedonic control really is the desire to eat for pleasure, not because of a physical need for food. And then you have the frontal lobe, which is involved in executive control. That's actually decisions made on in advance about when to eat, sitting at the table, ordering from a menu. That represents executive control. So you have these three different levels of control of appetite: homeostatic, which is a result of negative energy balance, and the body says, I need to refuel. The mesolimbic system, which is really eating out of a pleasure, and the executive control. And it's really the crosstalk between these homeostatic and hedonic eating. It's influenced by mediators from the adipose tissue, from the pancreas, the gut, and other organs. And we'll get deeper into that in just a few minutes. Cognitive functions in the prefrontal cortex exert what we call executive control on food choices and the rational decision to eat. And it's the interconnectivity of these neural networks which actually drives eating behavior and is shown to be altered in obesity. So we're not going to show an exam on this, but really the purpose here is to show how the large intestine, how the stomach, by virtue of being able to secrete ghrelin, which we'll talk about, which actually leads to increased appetite. The adipose tissue actually can secrete leptin, which actually leads to a reduction of appetite, and the pancreas as well can excrete leptin. And what happens, these organs are all involved in appetite, and they have their different effects in terms of the arcuate nucleus and the hypothalamus. So really what we're talking about is the important relationship between these peripheral organs and the brain in terms of regulating food intake and body fat mass. So what's interesting is that the adipocyte actually changes with weight loss and weight gain. So here we have in the obese state, we have our plump, round adipocyte. With that situation in the obese site, we have an increase in sympathetic nervous system tone, a decrease in sympathetic nervous system responsiveness, and the increase in leptin. And of course, the increase in leptin is saying, hey, I have enough energy, no need to eat very much. And you can see the arrows showing basically an equal flux in terms of the intake and excretion of glucose, triglyceride, and free fatty acids. Well, then now we're weight reducing. Now we're in negative energy balance. And what happens is this, you can see that the cell size of the adipocyte decreases. At this point, now you're getting a decrease in leptin levels. You're getting an increased flux because of that energy imbalance in terms of triglycerides and free fatty acids. But then we know that oftentimes with weight reduction, there are forces that lead basically to a relapse state. And in this relapse state, not only do you find that the adipocyte or the fat cell actually increases in size and increases in fat content, but in some cases, people feel there may be actually hyperplasia or an actual increase in the number of adipocytes. So why is obesity a chronic and recurrent disease? Well, first of all, during weight loss, energy stores are mobilized from the adipocyte, which is basically a reservoir of energy, and the adipocyte becomes smaller. During weight gain and weight regain, energy is reaccumulated, and the adipocyte becomes larger because it's storing energy. Weight loss causes actually the adipocyte to feel stressed, and this results in an altered metabolic profile to relieve that stress, which is really by increasing the storage of lipid and most of the time by virtue of increasing that desire to consume energy or food. Now, leptin and insulin are often referred to as adiposity signals because their levels generally reflect fat mass. So in fasting situations, both these hormones actually decrease with a decline in adiposity that occurs in weight loss. So what we see here, and this is why one of the reasons why chronic weight management is just so difficult. We have this chronic recurrent obesity. So with this obese state, we develop what we call leptin resistance. When leptin levels are high, which occurs chronically high, which occurs in the obese state. Remember, we talked about leptin actually reduces appetite, but what happens is you actually become resistant to its effect. And by virtue of a decreased effect, you actually have an increase in appetite. This increase in appetite leads to further weight gain, which leads to further leptin resistance, which leads to further increases in appetite. And associated with this is the development of insulin resistance. Insulin resistance leads to an increase of the counter hormone ghrelin, which is secreted by the stomach mucosa. And we talked about that's the one that turns on your appetite. And it actually has an effect both in terms of decreasing GLP-1. That's the agonist that we're going to talk about. So it decreases the levels of GLP-1 and decreases the level of this protein YY peptide, which is released from the gut in response to eating, signaling to the brain, hey, I'm not hungry anymore, so I'm good, and therefore I won't consume this extra energy. So you get decreases of those proteins in this chronic obese state, leading to its chronicity. The changes in these hormones directly contribute to enhanced hypothalamic expression. We talked about briefly the arcuate nucleus, neuropeptide Y, and the agouti-related peptide called AGRP, as well as decreased expression of another important neurotransmitter, propiomelanocortin. And what's important, one of the things that's important is this neuropeptide Y is actually one of the most potent peptides that stimulates appetite and actually leads to increased carbohydrate intake. It's also involved in regulating energy metabolism and delays satiety. So it makes it so you actually don't feel full as soon as you should. And these are changes within the hypothalamus in the brain that are called the anabolic state, leading to positive energy imbalance and weight gain. So these are changes that occur within the brain, within the hypothalamus, which leads to that urge to consume more energy. So really, a lot of people think a lot of the battle in terms of appetite is related to the battle between leptin and ghrelin. So we'll show a lot more information. Remember that ghrelin is given out by the stomach cells, leads to a increase in appetite, affects the vagal nerve, whereas leptin is given off by the adipose cells, adipose tissue, leading to a decrease in appetite. So ghrelin, the hunger hormone, it's released by your stomach when it's empty, signaling your brain that it's time to eat. It's fast acting and should dramatically decrease when you're full. It's at its highest level right before you eat, and it's the lowest about an hour after a meal. It signals the hypothalamus that your body is in need of fuel, leading to an increase in appetite. The problem is, in the obese, ghrelin actually decreases slightly after eating. So you actually have this increased persistent signal telling the brain that you actually need more food, and this leads to overeating. And some of the ways we improve ghrelin functions: avoiding sugar, high fructose foods, eating plenty of healthy carbs, whole grains, and actually sleeping more than 8 hours a day. Leptin is the satiety hormone. So leptin is a hormone released by the fat cells that tells your brain when your body has had enough fuel and can start burning fat to create energy. So it actually leads to a decrease in appetite. It's released by the fat cells in your bloodstream to let the hypothalamus know that your body has enough energy in terms of body fat and you don't have to eat anymore. The problem is, in the obese state, you have these chronically elevated leptin levels. And when that happens, the body becomes resistant to its effect. So we actually see that leptin doesn't exert its effect as much in obese individuals, and actually can be and is actually also caused by chronically elevated insulin levels that we see in insulin resistant patients. Again, sleep has a lot to do with it. Sleep is important, and adequate exercise to actually increase leptin sensitivity or decrease leptin resistance. So this neurohormonal feedback loop sustains the obese state. So in summary for this aspect, adipose tissue expansion leads to increase in leptin, insulin, and inflammatory cytokines. The hypothalamus in the brain actually becomes inflamed, leads to leptin and insulin resistance. Leptin resistance leads to an increase in appetite, decrease in satiety, and decrease in thermogenesis, meaning that's the adaptive thermogenesis, which is your basal metabolic rate. That's why it's so important to exercise, because without exercise, your basal metabolic rate, which is the degree of energy expenditure, increases during the course of the day. The energy surplus actually leads to further weight gain. Interesting that skeletal muscle efficiency actually increases, so you burn fewer calories per unit of work. And weight loss attempts lead to a decrease in leptin and insulin, increases in ghrelin, and decreases in the gut-derived satiety hormones. So weight loss, the body's really trying hard to fight weight loss. And that's why I think it's such a difficult situation to expect short-term gains to be maintained over the long term. I won't test you on this either, but this really shows what happens when you have energy restriction, decreased energy sources. You get this energy imbalance with decreased intake because you're decreasing your consumption, and at the same time, your expenditure of energy decreases. So you're taking in less energy, you're expending less energy. And at this particular point, what we could see is that the signals from the periphery, which are the green arrows, they convey a message of energy depletion. This is what we see, remember, in patients, we see the low leptin and insulin levels. And of course, this low nutrient availability favors signals in the brain which show that, which really result in hunger signals exceeding those of satiety and satiation. So again, the body's really trying hard to maintain that state of obesity. And when overfeeding, so when you're actually now in a stage of relapse, so you lost weight, now you're in the stage of relapse, what we see when overfeeding occurs, you get a persistent postprandial state, and this leads to traditional signatures of energy depletion resolve, and again leads to that cycle of caloric intake and persistence of the obese state. All right, so why is a cardiologist talking about obesity? So this part of the presentation will really focus on that aspect, the cardiovascular effects of obesity. So we know that adiposity is associated with major risk factors for heart failure in particular and other related comorbidities. The fat cell and the macrophage, which is the inflammatory cell, actually create a partnership. This leads to a whole milieu of effects, and this actually is compounded by ectopic lipids, which is lipids that we are consuming and stored in the liver and other places. So what's the result? Increased free fatty acids, increased inflammation, increased insulin resistance, increased insulin levels, increase in renin, angiotensin, aldosterone system activity, which we see in hypertension, increases in the sympathetic nervous system activation could lead to vasoconstriction and hypertension, mechanical effects. This leads to a situation where it's a fertile environment for the eventual development of heart failure. And I'm not going to test you on this, but this really just gives a list of the effects of obesity on cardiac performance. Increased blood volume, the heart has to stretch to take in that volume. The pressure in the heart increases. You get decreases in terms of systolic or the contractile function. You get diastolic dysfunction, which my patients know I call it the stiff heart syndrome, increased inflammatory state. And of course, you can see the insulin leptin insensitivity, enhanced activity of the sympathetic nervous system, activation of the renin, angiotensin, aldosterone system, leading to fibrosis, apoptosis, which is cell death, and hypertrophy of the heart. We see a lot of hypertension in the patients that have excess adiposity related to increases in activation of the renin angiotensin system, decreases in the protective neurohormones such as adenopectin, nitric oxide, et cetera, and increases in leptin, which actually lead to a disruption, what we call the hypothalamic pituitary adrenal dysregulation, which actually leads to increases in cortisol, which promotes fat storage, particularly of visceral fat. So we can see how the mechanism for how the adipocyte leads to hypertension. I have to say that by far the majority of patients I see who have hypertension are actually overweight or obese. Important relationship between obesity and cardiac arrhythmias. We all know about the relationship with atrial fibrillation. We know that you get an enlargement of the atria, you get fibrosis of the atrial tissue, you get accumulation of pericardial fat, which leads to increased inflammation around the heart. You get QRS fragmentation, fibrosis. Actually, many people don't realize that obesity is associated with ventricular tachycardia, ventricular fibrillation, and sudden cardiac death. This is how obesity and atrial fibrillation can occur together. With obesity, you get impaired diastolic function, increased inflammation, increases in this pericardial fat. What you can see on the bottom is as BMI increases, so does the incidence, the persistence of atrial fibrillation. And we do have some evidence that reversing this with the GLP-RAs can sustain that normal sinus rhythm and lead to less accumulation or less load of atrial fibrillation. Pathophysiology and heart failure. I mean, this is really, to me, where the issues really lie. We know that you get stiffening of the ventricle, you get accumulation of fluid and salt by virtue of the initial decrease in systemic vascular resistance. So you get increased activation of the renin, angiotensin, aldosterone system. All these factors play a big role in terms of the heart failure state. And I think I'm going to spend a fair amount of time talking about heart failure because the data is so good in terms of how these newer GLP-RAs benefit. So this looks again at the biology of adipose tissue and the maladaptive effects. You have the maladaptive renal effects. What we do see, for instance, in the obese population, this is of particular interest to the cardiologist, they actually have a decrease of the anti-natriuretic effect. So actually in the obese patient, you're seeing lower levels of natriuretic peptides in the heart failure state that you do see in the patients who are non-obese, non-overweight. The natriuretic peptides are a compensatory mechanism to fight heart failure. So if you're obese, ask your doctor to check your BNP or NT-proBNP level, because oftentimes people who are obese who say, I feel kind of tired, I don't have a lot of energy, they think it's just because, they're out of shape, whatever. Oftentimes these patients present with occult heart failure. So that's a very important thing to do. So here's the adipokine hypothesis of heart failure with preserved ejection fraction. We see that the evolution and progression of this heart failure, this is patients who have heart failure with normal contraction of the heart. They have what we call the stiff heart. So that's preserved ejection fraction. It really is related to the pro-inflammatory and pro-fibrotic signals that come from the adipose tissue, leptin and other compounds, coupled with the suppression and synthesis of adipose-derived cardioprotective signaling, such as adenopectin. So there really is this imbalance in the obese state for proteins and messengers that actually lead to thickening and inflammation. And that's certainly what we feel is the major pathophysiology for the development of heart failure. So we know that there's been a surge in the incidence and prevalence of HFpEF. This really goes along with the same increase in terms of the global epidemic with obesity. Visceral adiposity is a harbinger of subsequent development of heart failure with preserved ejection fraction. Central obesity, adiposity is present in nearly all patients with heart failure with preserved ejection fraction. And again, we most commonly assess that, though imperfectly, with the BMI. Both obesity, talking about visceral adiposity, and heart failure with preserved ejection fraction share a number of similar overlapping clinical presentations. And in obesity, visceral fat undergoes hypertrophy, greater inflammation, fibrosis in parallel, and with some of the other neurohormonal effects leads to the development of this stiff heart syndrome. Patients present with fatigue, shortness of breath, peripheral edema, et cetera. Again, I'm not going to get into this so much. We've talked about this, but this is some of the biology comparison between obesity and heart failure with preserved ejection fraction. The point here is they share many, many common attributes, and I think that's why efforts that we're going to see now and in the future relate to affecting this biology. And at this point, we're certainly doing that with the GLP receptor agonists. So what's the goal of weight loss treatment? The goal of weight loss treatment with anti-obesity medicines is to reset the set point, a term that describes a weight range the body tries to maintain and one which is elevated in the setting of obesity. When one loses weight by restricting calories, your body thinks it's starving. This spurs a person to keep eating to maintain an elevated set point. And anti-obesity medicines work in the brain to help bring that set point down, enabling individuals to not only lose weight, but also to maintain weight loss. So these are the kind of conditions where we see improvements by virtue of weight loss: diabetes, hypertension, fatty liver, a whole variety of cardiovascular diseases, osteoarthritis, but also cancer and sleep apnea, with data coming in that perhaps even with major depression. So this is the effect of the GLP-1 agonist, which many of us prescribe and many of us are taking. These are the effects of the GLP-1s. Decreased synthesis of glucose, less fat accumulation, decreased gastric emptying, which makes you feel full longer, effects on the brain, which decrease food intake, decrease reward behavior, effects on the muscle, increasing insulin sensitivity, increasing glucose uptake, therefore reducing sugar levels, reducing A1C, and in the pancreas, leading to increase in synthesis of insulin, leading to decrease of its cousin, the opposite effect, glucagon, decreasing beta cell death and increasing beta cell survival. Those are the cells in the pancreas that secrete insulin. So these are the currently FDA-approved nutrient-stimulated hormones. We call that NUSH, which are really the the injectable medications. We can see liraglutide, which is Victoza, Saxenda. These are the first generation. These are generally taken daily, and you can see weight loss about the 8% range. Semaglutide is the second generation, weekly injection. And what we see with semaglutide is weight reduction in that 15% range. And then we have tirzepatide, which actually has an effect on the GLP-1 and the GIP receptor agonist. And you can see weight loss. You can see a bit more than you see with semaglutide. You're seeing weight reduction as high as about 20%. These are the clinical trials in terms of outcomes. And what we can see up here, these are patients who were trials obesity with diabetes. So this is what allowed these drugs to really become more popular in the diabetic patient. You can see the leader trial with liraglutide, Sustain 6 with semaglutide, and Surpass CVOT with tirzepatide. And what you can see is you're really seeing now reductions of cardiovascular events in that diabetic obese population. With the first generation drugs, you're seeing 13% reduction. With semaglutide, you're seeing reductions of about 25%. We're waiting to see the results of the Surpass cardiovascular outcome trial with tirzepatide. But now we're looking at the obese patient without diabetes. We know actually what's interesting is you actually see less weight loss in the diabetic population than in the non-diabetic population. But you can see here with the SELECT trial with semaglutide, looking at patients who were non-diabetic with cardiovascular disease, reductions of cardiovascular endpoints of 20%. You can see with STEP-HFpEF, a reduction in enhancement of cardiovascular symptoms. Patients could be more active, significant increases. And the SUMMIT trial really represents a reduction in cardiovascular death, worsening heart failure. This is really a heart failure trial, obese non-diabetics. So the SELECT trial actually put the semaglutide on the map. This was a trial of obese non-diabetic patients who had established cardiovascular disease. So they had to have a heart attack, a stroke, revascularization. 17,000 patients over the age of 45 with BMIs of 27 or greater who were not diabetic. And this is, again, looking at what these patients presented. Most of them presented with coronary heart disease, such as infarctions, significant coronary artery disease stenosis, but some of them also presented with stroke and peripheral arterial disease. And of course, this is what we see. We can see that the primary cardiovascular endpoint, which was cardiovascular death, non-fatal stroke, non-fatal heart attack, 20% reduction on top of patients who are receiving very good standard of care. Heart failure composite endpoint, 18% reduction. Death from CV disease, there was a trend, it was not statistically significant, a trend of about 15%, and death from any cause, reduction of 19%. So now we're seeing in a drug that was used for diabetes in a non-diabetic obese population, these types of benefits. Major side effect from what we saw in SELECT was gastrointestinal disorders, and I think this occurs in about 10–15% of patients when we use any of the GLP-RAs. Usually it starts early and dissipates, but there's about 10% of patients that just don't tolerate them. Some interesting data. This is looking at the implications of weight loss. Interesting that in the placebo group, those that actually had the biggest weight loss actually had an increase in cardiovascular events. Interesting. Those that had, whereas in the semaglutide group, weight loss did not affect the cardiovascular event rate. So it didn't really matter how much weight you lost. So there's a disconnect between the weight loss and the cardiovascular benefits, which tells you, hey, maybe it's not all about weight loss. And in the placebo group, maybe it's about loss of the right kind of fat. Maybe it's affecting visceral and central obesity rather than, let's say, subcutaneous fat. And what's interesting, what we see here, even in changes in waist circumference made no difference in the placebo group who actually lost weight. Whereas in the semaglutide, the change in waist circumference really made a difference. So maybe it really matters how you lose the weight. Maybe it's the reduction of visceral fat rather than non-visceral fat that makes the difference. And remember, not only losing fat, but you're also losing lean body mass. So you're losing skeletal muscle, and even sizes of the organs will decrease. So the important lessons from the SELECT trial: no evidence that semaglutide effect on the major adverse cardiovascular events was mediated by time-varying weight loss. We may be focusing on the wrong goal. Early change in waist circumference was felt only to mediate about a third of the reduction in cardiovascular risk. So it's above and beyond weight reduction. There were no substantial differences in serious adverse events in patients treated with semaglutide, according to the strata of change in weight or waist circumference. Basically, in the placebo group, for some reason, those that lost the most weight actually did worse. So it really tells us there perhaps is a cardioprotective effect of semaglutide that extends beyond the impact of adiposity. Other important lessons we found from these drugs, they reduce blood pressure. Oftentimes, I have to reduce the blood pressure medications of my patients, reduce triglyceride-rich atherogenic lipoproteins, which lead to coronary vascular disease, direct effect on endothelial function of the lining blood vessels. GLP-1 receptors signal the brain that may modulate systemic inflammation and reduce it. And adiposity tissue biology changes actually before the mass of adipose tissue is measurably reduced. So we may be making effects just in terms of the fat cell biology even before we have weight loss. So it should not be assumed, important, that the lack of substantial weight loss on semaglutide precludes the opportunity for improved cardiovascular outcomes. So support the conceptualization that the GLP-1 receptor agonists actually have potential cardiovascular disease modifying effect far beyond weight loss. We'll talk just about the STEP-HFpEF trial for a second because I don't want to run out of time, but basically this was a trial of patients with heart failure with preserved ejection fraction with semaglutide. They looked at quality of life measures, and they actually found that the quality of life measures improved substantially. The SUMMIT trial now looks at tirzepatide. So this was looking at a heart failure trial with preserved ejection fraction. Tirzepatide actually has two hormonal effects. It agonizes what we call the GIP, or the glucose-dependent insulinotropic polypeptide, as well as the glucagon-like peptide receptor. They looked at patients with heart failure, the primary with preserved ejection fraction. The primary endpoint was a composite of death from cardiovascular causes or worsening heart failure, as well as looking at quality of life with the Kansas City questionnaire. And what we see here is also great data. We see basically this 38% reduction in terms of the composite of cardiovascular causes or worsening heart failure events. And again, the placebo group was a group that was on standard of care good therapy. I know because I was part of both of these trials as principal investigator. And so here you're seeing in the heart failure population a significant reduction in terms of events, CV mortality and worsening heart failure. And in this particular trial, they did look at the Kansas City cardiomyopathy questionnaire, and you can see that the benefits with tirzepatide far exceed the placebo. So basically, these patients felt better. They lived longer, they didn't go to the hospital as much, and they felt better. And here we see what's interesting is you certainly get more weight loss, it seems, with tirzepatide versus semaglutide. The chance of getting a 15% or more weight loss is further enhanced with tirzepatide versus semaglutide. But this was data that's actually published today. Real world heart failure data, semaglutide versus tirzepatide. We're looking at the risk of death and heart failure hospitalizations. In this real world data, no difference. So this really goes the fact, sure, you want to lose more weight, you can make a choice in terms of what agent you want to use, but the presumption should not be that the greater weight reduction is leading to a greater cardiovascular benefit. And there are a variety of situations that you should be aware of when people lose weight. Blood pressure medicines may need to be reduced. Consider repeat thyroid, TSH thyroid testing when there's significant weight loss, as you may want to change levothyroxine doses. We talked about issues. You may want to reduce, it may reduce the efficacy of some contraceptive therapies. And now we're seeing data, even in terms of addictions, where there may be some positive effects. There's a high discontinuation rate, so we really got to keep our patients motivated. Some people say they stopped it when they get to their ideal weight, but the problem is there's very high recidivism. And so we know that after about a year, this is comparing patients with type 2 diabetes, about 50%, about 45% stopped the GLP-RA, and in the non-diabetic, about 65%. Oftentimes, patients will stop the drug because, I'm at my weight, here I go. All right, let's talk a little bit about the effect of exercise. I tell my patients who are on these drugs, high protein diet, exercise, including resistance. In the obese patient, they may have a greater amount of muscle mass, but they actually have decreased muscle strength. The muscles don't work as well. And their global physical function, they feel like heck. Now, if you start these patients on caloric restriction, you're losing muscle. Muscle strength really doesn't change, but you start feeling better. Now you put caloric restriction and you couple that with a high protein diet, you're reducing your muscle mass loss. Not much effect in terms of muscle strength, but again, they feel better. Now you add endurance activity or physical activity, and you still see the reduction of muscle mass, no effect in terms of muscle strength. Now they're even feeling better. Now you add resistance exercise weights. Now you've negated the loss of muscle, increased muscle strength, and again, a good physical function. So the emphasis when you're on these drugs, high protein diet, exercise, but particularly resistance. Buy those dumbbells. And we can see with all of these drugs, you're getting reductions in terms of lean mass, which is often a large part of its muscle. You're getting reductions of somewhere between 25 and 45%. So don't think just because you're losing weight, you're just losing fat. A third to half of that weight loss is resulting in loss of lean mass. And now we have drugs that are in investigation that actually affect this pathway that leads to loss of bone strength as well as muscle. This myostatin activin pathway is one of them. And with this particular drug, you can see you get reductions of body weight, you get reductions of fat mass, but actually you get increases in lean mass. So the percent of in patients who are losing greater than 15% fat mass, you can see that it really has a positive effect in terms of increasing the fat loss versus negating the loss of muscle. So we'll see more about that in the future. We can see a lot of good things from the effect of GLP-RAs from a whole variety of cancers. The biggest cancers would be female genital, skin cancer, et cetera. These are the cancers that we see reductions in terms of incidence when patients are on the GLP-RAs. These are the weight loss medicines currently under investigation. A lot of them under investigation at the National Heart Institute. We're working in the REDEFINE 3 trial, which is actually looking at the third or fourth generation drugs. This is looking at semaglutide with an amylin analog. So amylin actually has incremental and synergistic effects in terms of weight reduction and anti-inflammatory effects. This is a trial that we are currently involved in. Another trial that we just started enrolling was the STEP-HFpEF trial. These are patients who have histories of heart failure, who are obese. And now we're looking at a drug called metabolic cafraglutide. It's an antibody that is an agonist of the glucagon-like peptide receptor, the GLP-1, which we all know about, and is an antagonist of the glucose-dependent insulinotropic polypeptide receptor, or GIPR. I'll talk a minute or two about bariatric surgery recommended with a BMI of 40 or greater in the Asian population, recommended with a BMI of 37.5 or greater, who do not achieve durable weight loss or improvements in comorbidities with non-surgical methods. These are the three most common methods. The most popular one is the sleeve gastrectomy. This is where you really see major effects. You actually see resolution of diabetes, resolution of hypertension, marked decrease in triglyceride levels. This is actually, when you get to weight loss in the 30, 35, 40% range, you're really seeing major impact on these disease processes. You can see looking out to 12 years, there's sustainment of that weight loss. We do know patients who get around it and can cheat, but the vast majority of patients, the weight loss is sustained out to 12 years. This is looking at the various types of surgeries that, in terms of the extent of weight loss. The Roux-en-Y actually gives you the biggest weight loss. Sleeve gastrectomy among those three gives you the least, and adjustable gastric binding is in the middle. And of course, look at cardiovascular events. You get major effects in terms of cardiovascular events. You don't really see the curves splitting out to about 6 years, but you can see that with time, there's incremental benefit. So fatal cardiovascular events and total cardiovascular events, we see big benefits with bariatric surgery. Be aware of iron deficiency anemia, vitamin B12 deficiency, folate deficiency, as well as calcium and vitamin D deficiency. If you go through bariatric surgery, it's important to maintain contact with your bariatric physicians as well as nutritionists. This is a really important point. It's the weight yo-yoing. When you weight yo-yo, gain weight, lose weight, gain weight, lose weight, you're replacing muscle by fat. With weight loss and weight regain, you actually get catabolism of muscle And with the weight gain, you get preferential fat regaining. So lean muscle mass is lost with each diet. Fat is regained preferentially and infiltrates skeletal muscle. Functional contractile tissues decline, reducing metabolic rate because you have less metabolically active tissue and functioning muscle. The result is a sarcopenic obesity, low muscle mass, high fat mass, reduced insulin sensitivity, and increased risk for diabetes and frailty. Resistance training during and after weight loss prevents a lot of this compositional drift. So you don't want to be yo-yoing. That's why people who actually go on these diets, they actually do worse with the yo-yoing of weight loss than just even staying in the obese state. So you want to avoid the weight yo-yo. That's why you really want to keep these patients on these therapies such as the GLP-RAs for a matter of years because of the recidivism rate, and we don't want to replace that lost muscle with fat. So this is our summary slide. Obesity is a chronic disease associated with many comorbidities. It's a chronic disease. Treatment durations need to be long-term. We're not talking about 6 months or even a year. We're talking about multi-year, perhaps lifetime. Obesity is a chronic disease. All we're doing is putting on the brakes, but at the same time having positive effects on in terms of cardiovascular wise, sleep apnea, in terms of even cancers, addictions. It's the interaction. The body works so hard to fight weight loss efforts to move off one set point. Interactions between the brain, intestine, stomach, and the adipocyte play critical roles in obesity. A multidisciplinary effort is necessary to maximize weight loss efforts. A variety of pharmacologic agents are available for the treatment of obesity that are now approaching weight loss observed with obesity surgery with new options in development. Obesity surgery is available as an important option for weight loss, and we're now seeing more clinical trial data showing the cardiovascular benefits of pharmacologic-induced weight loss, which is why I'm here today and why I treat weight loss. I am not a weight loss doctor. I am not an obesity doctor. I am a cardiologist with the goal of mitigating cardiovascular risk, and this is one of our tools to achieve that. Well, I thank you very much. Hopefully some of you got some important information, and I don't know how much time we have left, but certainly open for questions. Thank you very much.
You can unmute now if you want to
Okay,
ask.
bravo, Norm. Was really to the force of this subject, and it need, like many important things need to be repeated, because you can have obese people listen to one lecture and be convinced. They need to have repeated messages.
Okay,
So,
I agree.
yeah. Anyway, if anybody has a question to Norm, now's the time.
I have one, Mike Farku. Norm, thank you for an excellent overview. It really was comprehensive. I learned a lot, and I have some interest in the field. So thank you again. I think, Norm, the real issue with bariatric versus the incretin therapies, the semaglutide, tirzepatide, don't you think it's best we change the paradigm a bit to start on the meds, and if people don't lose weight, then go to bariatric as opposed to bariatric up front? Bariatric surgeons will argue with you that the people don't tolerate these drugs, they can't afford the drugs, and that bariatric is a more rapid way to get to the solution. But as you point out, a lot of these effects are pleiotropic and really may be independent of weight loss. So I'm wondering about, where do we go next in terms of our approach to the combination of medications and bariatric?
Well, thanks, Michael. I think one of the things I learned from my study of adiposity, which is really, I think, a better way of saying obesity, but adiposity, is that it's not all about weight loss. And I would suspect that, and I don't have any data to prove it, but I would suspect there would be incremental benefit of these incretins with weight loss surgery, because these effects, we can see all the neurohormonal effects. We can see perhaps effects on inflammation. My guess is that these therapies are actually synergistic. Now, I think that I would start, in my opinion, I would first start with pharmacologic intervention. There are patients who tolerate these drugs great and can have near obesity surgery-like effects, and they can do very well on pharmacologic therapy. There are patients either who can't afford it We know that if you look at a 10-year curve, that actually bariatric surgery leads to a lower outlay of dollars than, let's say, 10 years of current costing of the injectable GLP-RAs. So if someone can't afford it, they can't tolerate, we know about 15% of people can't tolerate it. If the effect is less than and does not reach goal, then I think that a bariatric approach with BMIs in that level is a good approach. And I think that I'm starting to see more and more of patients who are actually have undergone obesity surgery actually either started or continued on their incretin. So I think that we have a lot more to learn. So this is just, I'm commenting just on my feeling, but I actually look at these therapies as synergistic. And we also know there are people who cheat their way out of the obesity surgeries. There's a recidivism rate even among that. And we also know that, obesity surgery is not benign. There are very high rates of complications. You have leaks. This is surgery, which is, not a slam dunk situation. So we know that there's significant comorbidities, difficult to reverse. And so I agree with you. I think a pharmacologic approach is the first approach, but I think that there are synergies between pharmacology and surgery.
Any more questions?
There's a couple in the chat here. Someone says
David, feel free to
maybe
ask the
someone-
question.
Yeah.
Norm, can you hear me?
I do.
Actually, Norm, it's Renee. I'm on David's computer. And my question has to do with your mentioning about cancer. It was interesting you mentioned melanoma. I know you're a cardiologist. Do you have any thoughts on the use of these medications and controlling cancer or treating cancer?
I think that the data is, thank you, Renee. I think the data is nascent. I think we know that there's an association between obesity and cancers, breast, ovarian, pancreas, so we know that there are some that are more common than others. We haven't seen randomized trials showing reduction. Most of it is observational. But the feeling is that the reductions that we do see in cancer are really the result of, as I showed in one of the slides, perhaps a reduction in inflammation, this inflammatory drive, and development of new blood vessels we call angiogenesis, which certainly cancer cells really need to have in order to sustain their more rapid growth. So I don't think I would prescribe it to somebody just for cancer, but one of the things when I do talk about with my patients is we talk about, the risks and benefits, and the potential benefits would be the potential for possibly having anti-cancer properties.
Thank you.
Well, one of the things is intuitively, people with cancer lose weight. They became emaciated. So it's the weight loss is not affecting the cancer. And no one probably speaks about prevention of cancer with
Right.
it, but for that you need data of many years.
Right.
Just to add something, Norm, can you hear me?
I do. Who's this?
Bruce Miller.
Hey, Bruce.
Hey, just to add something, there are studies that show that these medicines work in inflammatory arthritides like rheumatoid and psoriatic arthritis, not just because of weight loss, but because of their anti-inflammatory effects.
Mm-hmm. Yeah, I think that, which is why I think there's synergy with, when Michael mentioned, the bariatric surgery. That's why I think there's synergy. I think these are important drugs, much more important than perhaps people realized when these drugs were first developed, when they were really developed for the treatment of diabetes. They had great, they would reduce, A1C by 1.5 to 2 points. So we saw a great effect, and then all of a sudden, we go from seeing the effects on hyperglycemia, and now we're seeing all these cardiovascular effects, which are really potent. I mean, I am a very active prescriber of two classes of diabetic medicines, the GLP-RAs and the SGLT2 inhibitors, both classes of drugs that were initially developed for diabetes, but the FDA mandated trials of new drugs to show that they weren't cardiac, they didn't have cardiac adversity. So what happened, these trials that the FDA forced on the drug companies actually led to great benefits. So, we're finding that, more and more benefits from this pharmacology, both the SGLT2 inhibitors and the GLP-RAs. So you're absolutely right, and I think you're correct about the inflammatory arthritides, which you're far more expert on than I am.
But we are looking for miraculous drugs, and every time we have a drug, we want to see if there are other positive effects. The same thing that happens with statins. But at the moment now, obviously, the only thing that we are looking forward is to lose weight, and the rest of the thing will come over time.
But remember, I think one of the important points I made, it may not be the loss of weight, it may be how you lose it as well, because there are no trials with the older oral agents that have shown cardiovascular benefit. So I think part of the cardiovascular benefit and perhaps part of the anti-neoplastic benefit may come from weight loss, but I think perhaps it matters which depots of fat. Are we decreasing visceral fat? Are we really having an effect on muscle mass? Is that where the weight loss is coming from? Because the weight loss includes both muscle mass and subcutaneous fat, which is why you get what they call it. They call it Ozempic face or something. So I think part of the benefits that accrue with these drugs, particularly when you use exercise, a high protein diet, particularly isometric exercise, is minimizing that loss of muscle protein and bone density. And so I think it really matters, which is why I think you really have to have a good grasp of the obesity disease state. And I think the important point is these drugs are not meant for, if they're tolerated, they're not meant for 6 months to a year. If you're really going to reset that set point, you should be on these drugs for years. Now, it may be when you reach your goal weight, you may want to say, okay, I'm at my goal weight. I don't have to take the drug every week. Maybe I take it every 10 days. Maybe I take it every 2 weeks, or maybe I reduce the dose. But I think that maintaining exposure to these drugs, my feeling is that that way you'll affect all those neurohormonal chemicals that are driving the hypothalamus in the brain to tell you that you're hungry and you need to lose weight. And I think that I hear from patients, that they'll walk by the refrigerator and not open it, where they used to open it every time they passed it. They would eat 3 bread baskets when they go to a restaurant, and now they're not eating any, and they don't feel like it. But I also have patients who love to eat, and the patients who love to eat don't like to lose weight, and they don't like, the GLP-RAs, but those are fewer and far between. Then you have about 15% of patients that can't tolerate it because of mostly GI side effects. So, the drugs have their limitations. And but I see them as a very important tool as a cardiologist to mitigate risk in my overweight and obese population of patients.
Let me tell the last comment. Stopping the medication reminds me of hypertension. Somebody is hypertensive, takes medication, blood pressure normalizes, and says, "What do I need the medication anymore?" And he stops the medication, and it goes back to 0.0.
And I think the important point is to really have an understanding. You need to check thyroid hormone levels in patients who are on thyroid hormone, issues related to the effectiveness of birth control, issues related. These patients their blood pressures will go down. If they have borderline blood pressures going on these drugs, you should probably reduce their blood pressure medications. So there are a variety of important factors. In diabetics, we should be careful and make sure they're getting their usual ocular examinations. I mean, we're now finding that the GLP-RAs, not only do you lose weight, not only do you get cardiac protection, you get vascular protection, and you get kidney protection as well. So it really is a trifecta or a quadrifecta of benefits that are accrued by these drugs. Like any other drug, you have to know how to use it, and not just you do that by studying.
All right, I think that we reached 10 minutes after the hour. I'd like to thank everybody that came to listen to Norm's lecture. It's not the last time, looks like, because there's so many things to develop, and we'll definitely invite you again. And good evening to all of you, and hope to see you again in the next lecture.
Thank you. Thank
And
you,
thank you
everybody.
so much, Norm.
Thank you, Norm.
My pleasure.